Hi, I'm Dr. Raj Aquila. I'm UK Ambassador and Global Key Opinion Leader in Facial Medical Aesthetics. Welcome to my series of online training webinars. During this module, I'll be sharing with you my techniques and secrets around patient assessment, surface anatomy, and facial mapping to enable us to assess our patients in a much more accurate manner to deliver excellent results every time. If we take our 31-year-old female patient here, we can see the upper third, which is from the hairline to the glabella, compared to the middle third, which is from the glabella to the nasophyllary angle, and the lower third, the menton, are appearing in a slightly different ratio. When looking at the upper third, we can see that it's elongated compared to the middle and the lower thirds. One of the causes of this is changes in the facial skeleton. We get a flattening of the frontal bone, and we also get an increase of the vertical dimension of the frontal bone. Also, the frontalis muscle becomes slightly hypotonic through aging, and we see a descent of the brow. Lift the brow and relax. Of course, shortening of the upper third can take place by injecting botulinum toxin in the glabella to facilitate frontalis hyperactivity, lifting the brow and thus shortening the upper third. Now coming down to the central third, this is probably her strongest third. However, there is one deficit, so we ask the patient to look down, look to the camera, and now look to the ceiling. And it reveals the presence of the infraorbital concavity, so the anatomical tear trough, and the lateral lid cheek junction. There's adequate projection in the lateral zygomatic arch and also in the medial malar fat compartment. So the discrepancy between the strength and the weakness, look to the ceiling again, is an indication for treatment. Now coming down to the lower third, things become more interesting. So we can see that there is elongation of the upper third when compared to the lower third, which is short. And the cause for this starts in the mandible, because through aging we know that there's less anterior projection, less lateral projection, and also less vertical projection of the jawbone. The second change is that we start to see the activity of the mentalis muscle rotating the chin upwards and shortening the lower third of the face. Our patient presented to us asking for beautification and moving away from becoming pretty and youthful into more high impact levels of beauty. So in summary, we have a youthful heart-shaped face that through aging will degrade by shortening of the lower third, a descent of the soft tissue of the lower third, therefore flattening of the lower third in relation to the width in the mid third. All of these changes mean we change from the heart into more like a square or rectangular shape. So treatment is in keeping with achieving the heart shape, maintaining, preserving and beautifying. Now let's focus on the upper third of the face. The indications here are a desired aesthetic ideal towards shortening of the upper third. And how do we do that? Well, of course, we can elevate the brow to shorten the upper third. We can inject botulinum toxin in the glabella to facilitate this and make the frontalis more active. But we can also inject directly into the brow, into the lateral part of the brow and into the apex of the brow to elevate and support the eyebrow. The final area is in the temple, and we can see here there is a degree of lateral hair clipping of the eyebrow through temporal hollowing because of aging and atrophic change at the deep temporal fat compartment. We can inject the temporal fossa to restore convexity in youth, but also as a balloon effect to give some elevation to the lateral tail of the brow and facilitate shortening of the upper third. So when injecting the upper third of the face, especially with dermal fillers, we have to be careful of vascular considerations. We know that the supratrochlear artery enters the forehead in this location at the supratrochlear notch. We know that the supraorbital artery enters in the corresponding notch in the midpupillary line and upwards supplies the muscle and the skin of the forehead. When the artery enters the forehead here at the supraorbital ridge, it's osseous. And from a supraperiosteal depth, it becomes more superficial as it ascends through the forehead. In other words, we see the artery passing through the frontalis and the aponeurosis, so we go from deep to superficial. Therefore, we can identify two injection planes by demarcating a 1-inch rectangle where this injection plane is superficial and this injection plane is deep. That way we don't inject into an artery and have an intravascular complication. Now moving down from the forehead towards the temporal fossa. The first anatomical landmark that's important to identify is the temporal fusion line, which is the suture dividing frontal and temporal bone. We can palpate this from inferior to superior as a small ridge or a crest. So we demarcate the temporal fusion line and also the limits of the orbital crest. The inferior part of the temple is demarcated by the temporozygomatic fusion line. So the temporal fossa has superior, anterior and inferior limits. The posterior limit of the temporal fossa is actually back in the hairline, so product must be restricted with your non-dominant index finger to avoid any spread into the fossa. The ideal injection point for the temporal fossa would be 1 centimeter lateral and 1 centimeter inferior to this temporal fusion line. We can demarcate this position here. We can inject at this position and leave our hyaluronic acid dermal filler down below the deep temporal fascia into the deep temporal fat compartment. The product will flow below the deep temporal fascia inferiorly and occupy the space of the temporal fossa. If we inject here, we minimize the risk of injecting through the thickest part of the muscle of the temporalis and thus reducing the risk of intravascular injection. Furthermore, it's important to demarcate the limits superior and inferior of the superficial temporal artery. We can do this by palpating the vessel with 2 fingers. So we have the superior and inferior limit, and then marking the artery as it passes through the temporal fossa. We know that injection away from the artery will result in less bruising, but also if we were to injure a perforating vessel that was connected to superficial temporal, then we won't inject into the vessel, we may damage the wall, but at least we're safe. So now coming down the face towards the cheek, we can see that our patient has adequate lateral projection here at the zygomatic arch. She also has really good projection at the point of beautification. Anteriorly, she may be slightly deficient, and that may explain the development of the anatomical tear trough here and also some of the lateral lid cheek junction. We can see here that we can correct the tear trough indirectly by placing product into position number 3 of the 8-point lift and also direct injection into the lateral lid cheek junction. Ask the patient to look to the ceiling, and then we can mark accurately the exact limits of the lid cheek junction. This, of course, is a soft tissue landmark. We also would assess the presence of the infraorbital rim, which normally sits around 5 to 10 millimeters higher. My marker is in red here because this is another no-go area to avoid breaching the orbital septum. Now coming down the cheek, we have the zygomatic retaining ligament, which would normally divide the lateral and medial parts of the cheek. So we can inject the lateral part of the cheek to develop a superior lateral lift, and we can inject the medial part of the cheek to develop anterior projection and also vertical elevation and indirect correction of the tear trough. Now coming down the face, we have the buccal maxillary retaining ligament. Again, another true ligament, cutaneous to bone, separating the nasolabial fat compartment to the upper lip. We know that treatment within the ligament and anterior to the ligament gives very good correction to the nasolabial fold. Coming further down, we have the mandibular retaining ligament from the oral commissure down towards the jawline. We know that treatment anterior to the ligament corrects the chin, and we get better union between chin and jowl. Now looking at the masseteric retaining ligament, which corresponds to the anterior border of the masseter, this being a false retaining ligament or having only a cutaneous insertion and no bony attachment. So we have a loose attachment here, we have firm attachment here, firm attachment here, and here at the orbicularis retaining ligament. The sequence of fat compartment aging is as follows. We have volume loss in the lateral malar fat compartment. We have a dehiscence and deflation and sagging in the temporobuccal region down towards the angle of the mandible. Then the medial malar fat compartment falls forward onto the nasolabial fat, giving deepening of the nasolabial fold. The buccal fat compartment is prolapsing down towards the jowl fat compartment, which gives heaviness here at the jawline. We know that lifting at point number 1 will correct the prolapse of lateral and medial malar fat compartments, and we know that injection at point number 7 is correcting the prolapse of the buccal onto the jowl fat. This sequence of facial fat compartment aging in combination with facial skeletal aging of course dictates our sequence and our treatment methodology for full facial rejuvenation. The 8-point lift starts in the lateral cheek at position number 1, then at position number 2 the optimum point of beautification, position number 3 for anterior projection of the medial malar fat compartment as well as vertical elevation of the tear trough, position number 4 here at the ala fossa, number 5 at the oral commissure, 6 at the prejowl sulcus for chin and jowl union, 7 at the angle of the mandible, and number 8 for treatment of lower cheek rhytids or to give a better blend between elevation and depression in the lateral part of the cheek. When injecting areas where retaining ligaments are present, we may find that the retaining ligament is causing a discrepancy between the elevation either side of the ligament. We can therefore use cannulas to bluntly dissect ligaments such as the orbicularis retaining ligament, zygomatic retaining ligament, mandibular retaining ligament, and here the masseteric retaining ligament. When injecting in the middle of the face, we tend to inject anterior to the ligaments to not add weight to weight. We know that injecting in the nasolabial fat compartment gives volume upon weight, and we get heaviness here at the nasolabial fold. So the nasolabial fat compartment therefore becomes a no-go area, so we must not inject in this area. Coming down the face now, the buccal fat compartment and the jowl fat are a corresponding no-go area. If we inject here, we add weight to this volume and we bring the jowl downwards and make the jawline look heavier. Now finally coming down to the lower third of the face. We want to steepen the angle of the jawline. We can do that by pulling the angle of the mandible upwards and superiorly. We can drop the apex of the chin down, and this gives a more dramatic and more impactful level of beauty. So now let's cover the strategic protocol for injection of the chin, prejowl sulcus, and the jawline to generate a vertical elevation of the jaw, an extension of the chin, and removal of the labiomental crease. Position number 1 would start here at the labiomental crease. We know that injection at this point will promote not just correction at the labiomental crease, but also an inferior extension of the chin downwards. It's also important to treat the labiomental crease in its lateral component as it starts to intersect here with the marionette line. It removes the shadow below the lower lip, but it also gives better relationship between the chin and the jowl region. The second injection point takes place at the apex of the mandible. We can inject on the anterior surface of mandible to promote anterior projection, or we can inject at the inferior part of the mandible for an inferior extension. The next position would be at the pre-jowl sulcus. We can demarcate this by stressing the skin, always injecting anterior to the mandibular retaining ligament to give union between chin and jowl. The final position for jawline contouring is here at the angle of mandible. The injection point corresponds to 1 centimeter superior medial to the angle itself.